afternoon. This presentation is made for educational purpose only and is made from material and pictures collected from various resources. I do not claim any ownership for this presentation, and I also do not have any conflicts of interest related to this presentation. Early childhood offers a critical window of opportunity to shape the child's holistic development and build a foundation for their future. Early childhood is the time to lay foundation for lifelong development. The Sustainable Developmental Goals prioritize early childhood development by recommending access to care and timely learning for young children. As pediatric dentists, we need to identify and assess the dental fear and anxiety or the pain related experiences of children and assess the same for proper behavior guidance while treating them. Assessment of dental fear and anxiety or dental pain and its consequences are an integral part of research in pediatric dentistry, including early childhood caries. Clinical and psychosocial impact of dental fear and anxiety include increased risk of dental caries, receiving poor quality dental care, missing dental appointments, and poor oral health related quality of life. Francis Galton, Darwin's half cousin, measured psychological characteristics. He called the measurement of these psychological characteristics as psychometry. Based on his work on psychological measurement, Galton is recognized as the father of modern psychometrics. Psychometrics is the branch of psychology concerned with the quantification and measurement of mental attributes, behavior, performance, as well as with the design, analysis, and improvement of the tests, questionnaires, and other instruments used in such measurement. Measures ascertain the size, amount, or degree of something by using an instrument or device marked in standard units. Psychological tests can be classified in many different ways as tests of maximal performance, that includes behavior observation tests or self-report tests, as standardized or non-standardized tests, as objective or projective measures based on the dimensions they measure and also based on the subject area. Children's self-report should be the primary source of information on DFA or pain intensity whenever possible on the basis of the age, cognitive and communicative abilities, and also the situational factors. Most children aged 5 years or older and many 3 and 4-year-olds can provide meaningful self-report of DFA or pain if age-appropriate tools are used by us. Psychometric measures of DFA during early childhood. Assessment measures for DFA in children are frequent in epidemiological surveys and research studies. However, in the dental clinical practice, the evidence suggests that dental professionals are unlikely to undertake formal DFA assessments routinely with their patients. This may be due to a concern that discussing DFA could be distressing for children, but in reality, DFA is reduced in patients who have used a DFA self-report questionnaire and are aware that the dental team has been given information about their fears and anxieties. Direct observation of a child's physiological response, direct observation of a child's behavioral response by the dental professional or researcher, or self-report questionnaires completed by parent or caretaker for a child, self-report questionnaires completed by a child or different assessment methods for DFA. The physiological measurements include blood pressure, heart rate, muscle tension, respiration rate, salivary biomarkers, skin conductance, and sweat tests. But they have their own limitations as these are non-specific, as it is not possible to attribute the results solely to DFA. Also, the equipment itself can evoke an anxiety response to the children. Also, specialist equipment may also be required for this. The behavioral rating scales includes Frankel behavior rating scale, the Wright's classification of behavior, Hoot scale, etc. The self-report questionnaires completed by parents or others. The use of parental proxy is intended to bypass the difficulty of comprehension or lack of cognitive ability in children, especially the younger children. However, many recent studies have highlighted poor agreement between proxy reports and child self-reports on DFA. A frequently used measure is the parent version of dental subscale of the Children's Fear Survey schedule. The correlation between parent responses and their children's dental fear and anxiety has been shown to vary greatly depending on the children's developmental stages. Self-report DFA measures completed by the child. The most frequently used self-report measures developed specifically for children with reasonable psychometric properties are self-report assessment measures for state DFA in children and also self-report assessment measures for trait DFA in children. State anxiety scales measure how anxious a child is feeling at that moment. The measures can also be used at different points during a treatment episode to monitor anxiety levels. Examples are Wenham picture test and facial images scale. Trait anxiety is the constant background level of anxiety about dental treatment. These scales measure individual differences in proneness to DFA. The examples are Children's Fear Survey Schedule Dental Subscale, Modified Child Dental Anxiety Scale, the Revised Smiley Faces Program. Wenham picture test is a projective psychometric self-measure test which is used to measure the level of dental anxiety of a young child. The pictorial scale consists of 8 pairs of pictures, each containing 2 cartoon figures of a boy with boldly drawn facial expressions depicting different emotions. The anxious figure in each pair will have a score of 0, whereas non-anxious figure will have a score of 1. The total score will range between 0 to 8. The facial images scale is an alternative picture scale that is quick to administer and also suitable for young children from age 3 years. Children are asked to choose one face from a row of 5 faces, a very unhappy face to very happy face that best matches how they are feeling at that time. The illustrations are clear, simple line drawings. The score ranges from 1 to 5, very happy to very unhappy. The FIS has also been used to with the measures of trait DFA, including the Smiley Faces program. CFSDS, the dental subscale of Children's Fear Survey schedule developed by Cuthbert and Melamed consists of 15 items, and each item can be given 5 different scores ranging from not afraid at all as 1 to very much afraid, that is 5. The cumulative scores can range from 15 to 75. It is suitable for 5 to 15 years age group. It is a well-known instrument for measuring dental anxiety in children. However, some of the items have questionable relevance for contemporary pediatric dentistry practice. Examples are level of anxiety about people in white uniform and going to a hospital that are irrelevant now. To overcome these limitations, an 8-item short form of this measure has been suggested. Psychometric measures of pain during early childhood. They can be pieces of at scale for 3 to 6 years and faces pain scale revised for 4 to 12 years. Graded dogs screening task can be applied for children initially before applying any of these psychometric measures. This consists of an image of three identical dogs, each increasing in size. Participants are asked, do you know what this is? What is it? And can you point to the biggest one? The task is intended to facilitate interaction with the child to check that participants are able to comprehend and respond to the basic questions and to demonstrate a concept of size. Any similar other task also can be used for this. The pieces of hut or poker chip tool quantifies pain intensity by using four poker chips to represent amounts of pain. Children indicate how much hurt they have by referring to one poker chip as a little bit of hurt, two as a little more hurt, three as more it, and four as the most hurt they could ever have. That the pieces of hurt tool has been used as a comparison tool to support the criterion validity of other pain tools such as the pain ladder and VAS or visual analog scale. Faces scales require selecting a picture of a face that represents one's pain intensity. They fall into two categories, drawings and photographs. An advantage of the drawings is that they can be readily and inexpensively reproduced by black and white photocopying. The drawings lack specific ethnic or gender features, so they may be applicable to a broader demographic groups than the photographic scales, which portray real boys and girls of selected ethnic groups. Facer scales may not require the ability to seriate or estimate quantities because the task can be handled by simply matching how one feels to one of the faces, which is presumed to be easier than quantitative estimation. Generally, children prefer faces scales to visual analog scales when given a choice to them. When you talk about self-report versus proxy assessment of child's pain, evidence suggests that school-age children are capable of validly and reliably assessing their own healthcare experience, and that using proxy assessments of a child's healthcare may not provide a complete picture of the child's own experience. Children and parents often disagree on what would improve their pain management, and children as young as 18 months have a language to speak about their subjective experience of acute pain. It has been demonstrated that most children aged 4 and older are developmentally able to use standard self reports of pain, demonstrating an understanding of pain as a subjective experience. Although self report pain scales provide an opportunity for direct measurement of pain, the use of these scales is not always feasible for children who are pre-verbal or pre-operational, non-English speaking, or unable to communicate because of intubation, sedation, severity of illness, or any other special care needs. If a child is unable to report their pain or there are concerns about the credibility of child's pain ratings, then parents in conjunction with pediatric nurses or other auxiliary play a critical role in recognizing and assessing the child's pain. Simplified faces pain scale and simplified concrete ordinal scales. SFPS. The three monochrome faces reflecting gradations of pain intensity were used in this simplified faces pain scale. The faces are designed to incorporate anatomical features consistent with facial expressions of mild, moderate, and severe levels of pain intensity scored as 3, 7, 10 on a 0 to 10 scale. Whereas SCOS is a concrete ordinal scale designed to assess children's self-reported pain intensity. The first image depicts a single block representing mild pain intensity scored as 3 out of 10. Second shows a stack of two blocks representing moderate pain intensity, a score of 7 by 10. And third shows a stack of three blocks representing severe pain intensity scored as 10 by 10. The anchor faces for pain scales have come under scrutiny in recent studies with the suggestion that a smiling no pain face has a propensity to increase pain scores and face with tears demonstrating more pain, most pain can decrease pain scores because children may not want to admit to crying or may believe that crying is a requisite of experiencing the most pain. The Wang-Baker measure has been criticized for potentially depicting emotion-based pain instead of physical pain as opposed to FPSR, which shows pain with less emotional valence. The most frequent words used by children from age 1 to 9 to describe pain were hurt, ouch, ow, with the latter appearing as early as 17 months of age. Most children understand the meaning of pain by 6 years of age. Similar research has been performed to discuss the language of satisfaction in young children aged 3 to 18. The words good, happy, and better were used to express satisfaction with pain management in a pediatric emergency department. Good and happy were used by children at all developmental levels. The words sad, bad, and mad were most commonly used to describe dissatisfaction. However, there was much more variability with the negative responses than the positive. Flag scale, that is, faces, leg, activity, cry, and consolability pain scale, used for children who are not able to subjectively rate their pain due to lack of cognitive and verbal skills. Observation of pain behavior is a validated approach of assessing pain. The flag scale is an observational behavior tool which has been validated in children from 2 months to 7 years of age and is used widely in a clinical setting. The scale considers typical pain behavior in the face, legs, arms, activity, crying, and consolability and scores each item from 0 to 2. To conclude, the good tests measure what they claim to measure, and any conclusions drawn from the test scores about the person taking the test are appropriate. That is called validity. Good tests also measure whatever they measure consistently, that is reliability. The concept of reliability and validity are central to determining whether a test is good or bad. The psychometric measures of DFA and dental pain have a role in research related to early childhood. There is a need to develop and validate developmentally appropriate skills or measures for children and those with special healthcare needs. And also, there is a need to develop language appropriate and culturally appropriate skills also. There is also a need to study the skills with different methods of presentation to the child in terms of sequence or order of presentation, whether it is a reverse order or forward order or random order, as well as by using technology. Thank you, the Ramachandra Institute of Higher Education and Research and the Center for Early Childhood Care Research for giving me this opportunity to present this topic. The team headed by Dr. Muthu, CC, CE, CCRE of Ramachandra Institute of Higher Education and Research. Thank you all.